Good evening. I'm Joe Flynn. I'm the Chief Administrative Officer for Norton Medical Group and the Physician-in-Chief of the Norton Cancer Institute. On behalf of Norton Healthcare, Norton Cancer Institute, and the Norton Healthcare Foundation, welcome to the 20th Annual Nixon Lectureship. Throughout my career at Norton, I've met some of the most amazing people who confront their diagnosis and treatment with courage and dignity, as I know you all have. I consider these patients, their families, and their caregivers my heroes. The Nixon family is an incredible example of this heroism. After 2 decades, the family's generosity has touched nearly every aspect of cancer care at Norton Healthcare through funding and their involvement in education, prevention, and treatment. And I can tell you they offer so much support to me personally that I'm extraordinarily grateful to them. I'm sharing a video with you tonight that gives you a glimpse into the work of our remarkable staff and the generosity of the Nixon family.
At Norton Healthcare, we strive each and every day to build a healthier community. Over the past several years, we've made great strides with support from community members like Bo Nixon and his family. It's through their generosity that the Nixon Lectureship was created in memory of Bo's late wife, Dotsie, in 2002. Decades later, the Nixon Lectureship is still going strong today, educating medical professionals and patients alike about the latest advancements in gynecologic cancer treatments so that we can continue to build a healthier community for years to come. The future is bright at Norton Cancer Institute. From infrastructure to technology, research, programs, and education, growth is constant. Each day, striving to eliminate suffering, striving to find a cure.
I think the research is going to get that good that if we can detect it early, then you can have a better outcome.
Edie Nixon's family has served as a pillar in the growth of Norton Cancer Institute. For decades, the Nixons have made generous contributions through the Norton Healthcare Foundation that have helped to bring to life special spaces for patients to reflect and heal, a quiet room, meditation room, garden, and more. They funded numerous programs to help continue the medical education of nurses and physicians. Most notably, the Nixon Lectureship, a free annual educational event that attracts nationally recognized physicians from across the country to discuss the latest and most innovative treatments for cancer. The event is open to the public. Speakers breaking down medical terminology so that patients and medical professionals alike can grasp the information, because everyone deserves to be armed with knowledge, especially when it comes to one's health.
The idea of reaching the underserved, of being able to promote education, not just with providers, but with patients. All of that is motivated by their desire to really fight and cure cancer, and also their love of community, their love of family, and their sense of giving back.
Giving back in hopes that no one else is taken too soon. It's through the lectureship that the Nixons honor the memory of one of their own, Dotsie Nixon, a woman revered in service to others. She died in 2000 at the age of 70 after a 7-year battle with ovarian cancer.
She did very well with what they had at that point, and the research and everything as it moves forward has just gotten better, so they're able to help women live longer.
Norton Cancer Institute oncologist Dr. David Deering cared for Edie's mother, building a special bond with the Nixon family. He vowed to help honor Dotsie's memory through the creation of the Nixon Lectureship. Since then, it's grown in attendance from dozens to hundreds, spreading awareness of the difficult-to-detect cancer known as the silent killer.
Gynecologic cancers don't get the press that breast cancer gets, or lung cancer, or even prostate cancer. It's important to raise community awareness.
Since the inception of the Nixon Lectureship, Dr. Deering has witnessed great advancements in the prevention, detection, and treatment of ovarian cancer.
When we started this lecture series, the treatment for ovarian cancer was basically 2 chemotherapy drugs, and the response rates were pretty high, but the relapse rates were very high.
Today, patients are living longer thanks to advances in chemotherapy and immunotherapy, bringing hope to the Nixon's mission. Edie envisions one day there'll no longer be a need for this lectureship.
Because that means ovarian cancer will be, I'm not going to say necessarily cured, but under control. People will have early detection, and then it'll be getting the word out that, hey, this is the test you need to do, or this is what you need to do to make sure that you don't get it.
Support from the Nixon family and others allows the Norton Cancer Institute to flourish as it celebrates many decades of caring for the community. The expertise of our staff and physicians is why Norton Cancer Institute cares for more patients than anyone else in the region. Although continued advances in cancer detection, research, and treatment have resulted in a decline in cancer death rates, cancer still ranks as the second highest cause of death in the United States. Providing provider education programs like this one, which ultimately benefit the community as a whole, are important components of the work that Norton Healthcare does as a not-for-profit healthcare system. These programs are vital to arming our healthcare providers with the information they need to help the patients we are so privileged to serve. That's one of the reasons why we are so grateful to the generosity of our special guests, the Nixon family. This lectureship is sponsored by the Norton Healthcare Foundation's Oncology Education Prevention Fund. This fund was established by Governor Dossie Nixon when Ms. Nixon was diagnosed with cancer. The purpose of the Oncology Education and Prevention Fund is to provide education assistance for the benefit of the adult-based oncology treatment and research programs of Norton Healthcare and the Norton Cancer Institute. Thanks to this amazing family, which continues to play an active role in Oncology Education and Prevention Committee, which overserves this fund. Tonight's program will focus on the diagnosis and treatment of cancer in older adults and their survivorship care. Our special guest speaker is an old friend of mine. I'm old, she's a friend, but it's really a pleasure to have Dr. Ashley Rosko here tonight. Dr. Rosko is an associate professor of medicine in the Division of Hematology at The Ohio State University and is the medical director of the Oncogeriatric program at the James Cancer Hospital. Her research is focused on cancer and aging, specifically on health outcomes of patients with hematologic malignancies, including multiple myeloma, of which she's an international expert in bone marrow transplant. She created and directs a multidisciplinary clinic to support older adults with cancer, founded in the principles of geriatric oncology. Her research is focused on incorporating assessments of physiologic age into clinical trial design using aging biomarkers and standardized tools to globally evaluate the health of older adults. I'm excited to hear our talk tonight, The Age of Oncogeriatrics. Welcome and thank you for joining us tonight, Dr. Ashley Rosko.
Thank you so much, Dr. Flynn, for having me. I'm very excited to virtually be with you all tonight and really to get you excited about the scientific advances behind cancer and aging. I'll go ahead and share my screen so we can get started. Today's objectives are to be able to determine the unique challenges of older adult patients with cancer in terms of understanding the impact of cancer with aging for older adults, specifically to look at accelerators of aging and measurements of physiologic age, and also how we can integrate these assessments and plans into your own practice that are patient and cancer specific. When we talk about aging in the United States population, in many, as we get older, there are chronic conditions that can accumulate as someone gets older. For those of you who are in the clinic, previously, many of your patients present with a median age in their 60s, often seeking care for chronic medical conditions. Well, more recently, we're seeing lots of older adults, those well into their 80s, that are thriving and are active and are doing quite well. In fact, I like to coin the phrase that 80 is the new 60 when it comes to patients presenting in our clinic. But importantly, this inversion that we're seeing when it comes to the demographics of our US population, where we have more older adults than we have younger adults, has never ever occurred previously in the US Census. I used to use words like this is an epidemic or this is unprecedented when it comes to the number of older adults that are here in our US population compared to the younger population. Although in light of the pandemic, things like unprecedented, it never happened before, I think we're all wanting to get back to normal in those sense of those terms. And so this is so important to understand the number of older adults that we're seeing within our clinics, how to be able to best care for them. The population growth in the US is increasing. 1 in 5 adults will be 65 years and older. When we look at the population demographics, there are variations when it comes to different demographics by state. For example, there are many older adults that are in Florida, West Virginia, Maine, Montana, and Pennsylvania. And it's expected that this will increase from 73 million to 78 million older adults that are going to be 65 years and greater. This unprecedented growth in this US patient population that we're experiencing, we need to be able to best care for the older adults within our community, specifically when it comes to chronic illnesses. I also would like to pay attention, especially when it comes to those who are living in Kentucky and Ohio. We're unique in the sense that we have many older adults who are in rural populations. When we look at the Appalachia area, that's 65 and older, we've seen kind of an increase in those who are 65 and older that approach 20% or greater. This is particularly important when it comes to treating chronic conditions with those that live in the rural communities. And why does this matter so much? It's because cancer is a disease of older adults. The median age of diagnosis for all cancers combined is around 70 years of age. This is looking at this year's census here. Not only that, cancer is predicted to surpass heart disease as the leading cause of cancer death. So if you look at this line here in terms of heart disease in the green and looking at the blue columns here, this hasn't happened before where we're seeing more cancer cases and more people who are dying related to cancer-related death. When we think about these patterns in terms of new cancer cases and we look over it over the course of time, the incidence of cancer per se has not necessarily changed significantly from 2015 until 2020. This blue line here gives us an estimate of the projected or incidence of cancer cases over the course of time. But we do see trends in cancer when it comes to different changes that we see. When we're looking at these trends and incident cases identified here, specifically if we're looking at white females, we can see that there was a 20% increase in the change of risk. Specifically, this had to do with hormonal therapies that were offered. But in the 90s, there was a 34% growth in the population. And so then we see this shift in the demographic here. And then more recently, we're seeing this aging of the US population. And so therefore, we're seeing an increase in cancer cases with the aging. So these three factors, when it comes to change in risk or growth of population, or the aging of a population is in which case we'll see a change in the cases within our clinics. Importantly, aging impacts every aspect of the cancer care continuum. Aging influences risk of developing a cancer. Certainly, age influences clinical decision-making, and we'll talk a little bit today, actually the focus of this will be how much does chronologic age influence clinical decision-making. When it comes to a cancer that I take care of, multiple myeloma specifically, age impacts survival significantly. If you look at the separation of these three curves when it comes to outcomes and percent survival, they're very different based upon how old someone is. And not only that, the number of older adults who are surviving is also increasing, which is a wonderful attribution to the types of treatments and survivorship care that we have for older adults. We're also facing a number of older adults who have survivorship challenges that are different than younger adults with cancer diagnosis. Importantly, it's recognized across many of these national leading societies and comprehensive cancer networks to recommend that all older adults aged 65 years and older undergo a geriatric assessment. Importantly, there's this recognizing the landscape of older adults in the cancer intersection is very relevant. I sit on the NCCN Older Adult Oncology Guidelines, and understanding the risk factors and unique factors associated with the principles of geriatric oncology care is recognized. Recently, there was a manuscript that was identified really emphasizing the impact of addressing vulnerabilities when it comes to older adults with cancer care. So what is a geriatric assessment? A geriatric assessment is a multi-dimensional assessment to characterize physiologic aging. It's based upon the domains of geriatric oncology, where we describe the parameters of a geriatric deficit, including things like physical function impairments, cognitive abilities, identifying and enumerating their comorbidities, socioeconomic stresses, things like social support, caregivers, transportation, understanding needs like income and financial challenges, the psychological state in terms of assessing and characterizing depression, distress, and anxiety for patients who come into the clinic, characterizing geriatric syndromes, things like dementia, delirium, falls, and failure to thrive, medications. Polypharmacy is incredibly important when it comes to our older adults who come into the clinic, understanding the number of medications, high-risk medications, and nutrition, specifically for patients who are losing weight, understanding their access to nutritional support or food insecurity is really an important part of a geriatric assessment. If we think about the 4 cardinal domains of a geriatric assessment, it's functional status, physical health, social and environmental assessment, and psychological well-being. Importantly, to be able to understand a geriatric assessment and the needs of an oncologist and our patients, and also our primary care doctors, we need to be able to create alignment between the needs of the older adult and the resources that are identified within the community. This is important, particularly in light of COVID, because the number of specialists is expected to increase. There's going to be a shortage of physicians, anywhere from 37,000 to 124,000. This was a report that was just put out through the AAMC, looking at the need for primary care physicians, including those who specialize in geriatric medicine. You can see that the shortage of physicians is estimated somewhere to be between 17 and nearly 50,000. In some specialists like oncologists, it's a lot lower. But importantly, this assessment was the AAMC report in terms of the shortages of physicians who practice things like geriatric medicine was not done in the COVID era. It's expected that 2 out of every 5 physicians will be 65 years and older, and 40% of physicians felt burned out at least once a week during the COVID pandemic. These demand for physician services is expected to increase. If we look at the physician needs here, and if you look at this color coding here, where purple is the least physician shortage, mostly identified in the northeast part of the United States, and looking at the red and the orange is estimated to be a higher the highest amount of physician shortage. We can estimate in 2030 that this is only going to get worse over the period of time. If you look at the states that were represented here, we see on average you get a marking of around a C or C- when it comes to the number of physicians that's needed. And this is important, especially when it comes to geriatric oncology services, because there needs to be a partnership of expertise, being able to understand the needs of patients in seeing their physicians specific to cancer care, and then also partnering the alignment of those needs related to aging. And as such, we're seeing the emergence of these multidisciplinary clinics that are focused on cancer and aging. Previously, oftentimes when an older adult was in the clinic and they needed the resources specifically, they were referred to back to their primary care physicians or to geriatricians. But because of this shortage, because of the need of the older adults that we're seeing within our clinics, I want to talk to you a little bit about how we built an oncogeriatric program here at Ohio State and how we're able to best serve our older adults specifically. So I'm going to talk to you about the pillars of our oncogeriatric program, which are focused on research, outreach, education, and clinical care. Today's focus will focus primarily on the clinical care and the research that we have done here specifically. The OSU Oncogeriatric program really focuses on synergy across divisions, departments, colleges, and programs. There are many investigators who focus primarily on gerontology, such as the section of geriatrics or the Office of Geriatrics and Interprofessional Aging Studies. In order to create alignment across these divisions really requires champions in each one of these sections to be able to build and bridge resources specifically for older adults with cancer. Not only that, our focus of our clinic has focused on our allied health services and how to integrate the expertise of others into our clinics to be able to build a multidisciplinary clinic with a multi-department group of leaders focused on improving the quality of life for older adults. Specifically within our clinic, we have a multidisciplinary team that is focused on a group of physicians. Myself, when we created the Cancer and Aging Resiliency Clinic, but also with the recruitment of geriatric oncologists, palliative care physicians and specialists in this area. We also have a team of audiologists, in addition to a dietitian, registered nurses who focus on the cognitive assessment of patients, physical therapists, case managers who are able to coordinate the care across the clinic, as well as dietitians who can focus on things like weight loss, and pharmacists as well. For those of you that don't know, Dr. Flynn was really a chief sponsor for the development of this clinic when I first came to Ohio State. And without his sponsorship, I'm not sure that any of this would have been able to come off the ground, but really was pivotal when it came to creating of this clinic. And I'm not sure if he knows that, but it was something that we had talked about, but built over the course of many, many years. And it wouldn't have happened if I didn't have his sponsorship and support. This is our clinic here, where our team is discussing our patients, and I'm going to talk a little bit about this. This clinic is called the CARE Clinic, which is the Cancer and Aging Resiliency Clinic, where we have this formal hearing assessment, memory testing, and medication issues, and nutrition, physical therapy, and a focus on health-related quality of life. In building the Oncogeriatric research program, we started in hematology, but have built out to expand medical oncology, transplant and cellular therapy, palliative care. We're also intersection with surgical oncology and survivorship. In addition to the clinical care, we've also built up the basic science program to be able to offer a translational science aspect to our cancer team. When patients come into the clinic is very prescriptive in the sense that when a patient comes into the clinic, we're using the multimodality assessment and the expertise of others to be able to align and create a very comprehensive assessment for our patients, but also importantly, a focus on optimization. So when a patient comes into our clinic, they're seen by the physician in terms of an assessment of their quality of life, asking questions like, what matters most? Characterizing frailty, identifying geriatric syndromes in a very prescriptive way. The impact of hearing loss can't be underestimated for a patient who comes in the clinic. All of us are feeling this with it now when we're wearing a mask at this period of time. We're seeing that how much hearing loss has impacted our ability to communicate to one another. So we have a formal hearing assessment within the clinic. Not only that, we have a dietitian who focuses on the mini nutritional assessment to be able to characterize weight loss, access, swallowing, dysgeusia, things that matter when it comes to the ability to eat, to enjoy food, on chemotherapy, on radiation, and also to be able to optimize weight over the course of time. We have a nurse who specializes in and trained in doing a formal memory assessment. We use the MOCA testing, which is a formal test for us to be able to characterize memory, orientation, concentration for a patient throughout their chemotherapy course. Many of our patients suffer from something called chemo brain, where we see deficits when it comes to attention, but understanding that these deficits are real and watching the changes over the course of time is really important. We have a case manager who focuses on activities of daily living, as well as independent activities of daily living to be able to characterize their needs best at home. And a physical therapist who was able to measure objectively a functional status based upon the short physical performance battery and the TUG systems. Not only that, the pharmacist is able to optimize their medications and identify high-risk medications. All of this is done in a prescriptive fashion where patients are focused on both assessment as well as an optimization of their health using these resources. This is a one-stop shop for our patients. That's something that is this systemic evaluation using the standardized geriatric assessment allows patients to get a one-stop shopping to come into this clinic, and all of these resources are centralized for the patient in order to be able to test their plan. So from that, I want to go over some of the data that was generated from our clinic. Specifically, when we look at geriatric deficits, looking at things like functional impairment, weight loss, polypharmacy, we wanted to look at whether or not that these geriatric deficits were associated with survival. When we look at on the graph here, we look at for patients who had no geriatric deficits when they were measured here. And I would say at this important time is that a lot of the things that we're done in this clinic is not part of routine care specifically. Looking at things like hearing loss or formal memory testament is not something that can be readily applied to a standard oncology clinic. And so if a patient were to have no geriatric deficits, we could see that their survival estimates were quite good. But if patients were estimated to have anywhere from 5 to 8 deficits identified here in the red curve, that their survival was impacted in a negative way. In addition to that, we are able to measure frailty using a rigorous tool, which we'll talk more about. The same can be said for identifying frailty specifically. We see less separation when it comes to frailty, but for patients who are managing well or slightly vulnerable, we see their survival probability to be similar. But patients who are identified to be frail, we can see differences when it comes to their survival probability as a whole. Not only that, so in the clinic, it's important to recognize that when we're doing a geriatric assessment, we're not only doing the assessments, but we're also doing interventions for those patients. We're not necessarily providing a list for their primary oncologist to do and to carry out, but when we focus on the clinic, we really focus on their deficits, characterizing them and providing interventions. But not all deficits necessarily have interventions, and not all geriatric deficits track with frailty. As an example, if we look at, so this is the percentage of patients who receive geriatric interventions, we see that many patients, especially as they become more vulnerable or more frail, receive a lot more of a lot more interventions focused on functional impairments, things like we prescribe physical therapy, obtain durable medical equipment to make their home safe, and to be able to provide occupational therapy so they can thrive either during their cancer therapy or throughout their cancer trajectory. And we also identify patients many patients are identified to have polypharmacy or require interventions. That could be dose reductions, medications that are discontinued, stopping other medications like herbs or supplements that may interfere with chemotherapy or something like that. But there are less interventions focused for patients who have psychosocial distressors. This is an area that really needs improvement in terms of identifying if we have patients who are having psychosocial stressors, how we can best serve them. Not only that, many of our patients were identified to have hearing impairment, but it didn't track with frailty per se. Many people who are healthy and thriving and doing quite well may need audiology interventions to improve their health-related quality of life, but don't necessarily track with frailty. So we're going to focus for a moment on physical function. Physical function is one of the most valuable predictors of outcomes. Why is that? Because there are aging-associated vulnerabilities that impact gait across the board. This is an example for patients with hematologic malignancies in terms of the ability to walk at a rate of 4 meters in time. Many systems coordination, the central nervous system, the peripheral nervous system, the musculoskeletal system, and the energy and production delivery are really an important part of that. Not only that, gait speed can be able to predict outcomes such as hospitalizations, emergency department visits, and survival. This is an example in our studies where we looked at geriatric function metrics in patients who were admitted for bone marrow transplant. We were able to predict the hospital length of stay based upon their baseline short physical performance battery. A short physical performance battery is a test that we can do in clinic. We ask patients to sit up from their chair, to be able to walk a short distance, and to be able to pivot and turn around. And from that assessment, we can identify and estimate reliably how long a patient would stay in the hospital. But important, something like deficits in physical function are modifiable. These are things that we can improve upon. We have resources that we can utilize for patients to be able to improve this, to decrease hospital stays, and to decrease hospital readmissions. So when it comes to our comprehensive geriatric assessment, where we do this multidimensional assessment and we have the interdisciplinary team and individualized care plan for them. So it's important to not only to assess these and to get the data regarding their cognitive deficits when it comes to a geriatric assessment, but importantly to focus on interventions and implementation. So being able to gather the physical therapy and occupational therapy, the medical equipment, to be able to address their transportation, their financial stressors, and medications within the same visit. And importantly, as many of you know, not only is it data gathering and implementation, but it's also monitoring and revising the geriatric assessment intervention piece. That's an important part of their survivorship care plan. One of the things that I want to focus on is this concept of frailty. Now, frailty is a term that's thrown out there pretty often. And I love this quote here where it's frailty is a term that's used more frequently than defined. And I think that's really important because I think that many of us can say that, or see someone perhaps that's frail and you can see it, and you can sense it, but what is it really? And how do you measure it? So importantly, I want to emphasize that this is a complex syndrome of physiologic decline signifying increased vulnerability. But this is measurable. This is something that we can identify within the clinic to be able to identify, to be able to optimize over the course of a cancer diagnosis. There are many ways to characterize frailty. This is one of the ways that we characterize frailty within our clinic using the clinical frailty scale. We provide both a visual and a description of what the clinical frailty scale is in terms of patients who are coming to the clinic. A second way to be able to identify frailty and to be able to rigorously address frailty is using a phenotype called the Freids phenotype, where we look and measure at things like unintentional weight loss, self-reported exhaustion, if there's weakness, a slow walking speed, and low physical activity. The Freids frailty type has been predictive of falls, worsening mobility, hospitalization, and death over and over again, not necessarily in a community dwelling population as well as a cancer population. One of the ways that we characterize frailty within the clinic, we're able to identify that there are really two types of frailty that we're seeing in patients, and perhaps you see this within your patient population too. In this study, we are looking at patients who presented for assessment of an exercise intervention. So this is their baseline testing that we were able to characterize for patients before they were enrolled into an exercise study. This is using a heat map to be able to characterize deficits according to our into the frailty scales. Patients were identified to have high evidence of, say, comorbidities or depression. They look red on this heat map, and if patients were had lower, for example, function or low social support, they were characterized as blue on this heat map. So in this study population, we identified a population that didn't have a specific signal that's identified here within the green. But then we also identified patients who were quite fit in terms of having low depression, low anxiety, high physical function, and good mental health. But then we were able to group out these other two groups that were considered to be more frail. We have the group that has more high comorbidities, high depression, high anxiety, and low emotional and tangible support that's identified here in the blue. And then a second group of frailty, which we called the functional frailty, that had really poor quality of life, poor and low physical function and low physical health. So these two types of frailty were actually quite distinct, and those who had more comorbidities and those that have very low quality of life related to their function. So importantly, a geriatric assessment benefits are very well characterized, and this is a summary that we put together that really said, geriatric assessments are important. They help when it comes to treatment toxicity, health-related quality of life, and hospitalizations. These are several studies in which if you had either a geriatric assessment or a geriatric intervention, that you could reduce treatment toxicity, that you can improve health-related quality of life, reduce hospital stays, reduce ICU stays in terms of being able to embed these well-characterized tools as part of routine oncology care. So in this first half of the talk, we talk mostly about health when it comes to our comprehensive geriatric assessment to be able to clinically evaluate someone when it comes to nutritional impairment, cognitive changes, gait, quality of life, strength, and psychosocial strength. But one of the things that I want to talk about next is how we're able to gauge health biologically. So clinically, we're able to characterize them robustly. It's associated with many, many clinical endpoints that are of value. But what are new ways for us to be able to gauge health? So I want to talk to you a little bit about biomarkers of aging. So a biomarker of aging is a powerful tool for the field of geriatric oncology. The AFAR definition of a biomarker of aging is a better predictor of lifespan than a chronological age itself. It can monitor the physiologic process and not the disease, be simple, not harmful, reproducible, predict a physiologic capacity, and is potentially testable in a small animal model. Now, to many of you, that may sound like the holy grail, but I think in many cases, we're getting closer to be able to examine what a biomarker of aging is and how we can use that to make treatment decisions for older adults. For example, if a patient came in, whether or not they had a treatment intense decision, say a major operation, or something alternatively that could be used with radiation, perhaps a tool like this could be powerful to be able to make treatment decisions in concert with their clinical health. So this concept of age-based biomarkers is really comes under the field of the geroscience, geroscience field. So the geroscience hypothesis is that there are shared biologic mechanisms of aging that increase susceptibility of aged individuals to chronic diseases like cancer. And this is based upon the hallmarks of aging. These hallmarks of aging are well established and well characterized to be associated with the aging process, and that potentially you could target and identify such a driver of the aging process to be able to delay the onset and progression of multiple chronic diseases, including things like cancer development and cancer progression. So when it comes to the geroscience criteria, the same type of things that are being explored. Something that's reliable and feasible, relevant to aging, robust and consistent, that can predict all-cause mortality and clinical and functional outcomes, many of which we've described here in our talk, as well as that they could potentially be responsive to interventions. There's a couple studies that are ongoing to be able to such as senolytic studies, to be able to characterize and identify senescent cells and remove them from the system. Today's topic, we're going to talk about some of the molecular signatures of aging and why that's such an exciting area. So I talked to you a little bit about what we profile here at Ohio State in terms of aging biomarkers. We work in partnership with Kristen Bird in the Department of Molecular Genetics, in which we have been analyzing for several years now, taking just 20 mils of blood, which is identified here within 2 tubes, and to be able to look at molecular markers using a nanostring DNA technique, to look at epigenetic age using DNA methylation, as well as looking at flow cytometry and cytop to be able to characterize some markers of senescence within the cells, as well as cytokine signals that come from inflammatory mediators that are known to be related to cancer progression. So importantly, one of the markers that we study is a marker called P16. So P16 is identified in peripheral blood T cells. It's related to chronologic aging. It changes approximately 10-fold over the human lifespan. It's something that is associated with senescence and also other lifestyle influences. So we know that there are certain things that can increase P16, such as chemotherapy or smoking. We also know that there are things that can decrease P16, which is associated with cellular senescence, such as exercise or caloric restriction in animal models. Not only that, there's been several population studies that look at polymorphisms of this molecular marker called P16, in which individuals from long-lived families taken from skin samples have lower P16 than expected chronologically. So one of the studies that I'm going to talk about is where we measured patients' peripheral blood T cell P16 prior to a bone marrow transplant, and then remeasured P16 after their recovery. We wanted to explore the relationship with this molecular marker with aging and related to frailty and other outcomes such as morbidity and mortality. So in this study, we identified when a patient, this is specifically to our multiple myeloma patient population, prior to a stem cell transplant, when a patient was diagnosed with a cancer such as multiple myeloma, a less common blood cancer, there was no significant change with P16 shortly from a diagnosis alone. We did identify that as patients got treated, that patients' P16 did increase. But we didn't necessarily see that the beginning part of their therapy increased P16, but we did notice some changes related to their bone marrow transplant. When we looked at patients who presented after their transplant 90 days into the recovery, we noticed a significant increase in their P16, which is a molecular marker of aging, and a significant acceleration of the aging of the T cells within this population. The acceleration of the aging was equivalent to 33.7 years of chronologic aging. And this is really important because for those of you who do transplant or have seen patients who have been through a transplant, you can see some of this physiologic aging that we see in the patient population. They're at risk for other cancers. We've known from other studies that transplants associated with the phenotype that accelerates aging. Here we can characterize it in their blood. And that's an important study for us to be able to identify that we can reproducibly identify these changes of aging within peripheral blood T cells. This therapy, in this case, ours was a transplant-induced molecular aging, but there have other studies that have been done in breast cancer as an example, which shows that patients that receive anthracycline chemotherapy to those who received hormonal therapy also experience this accelerated aging of their T cells within their peripheral blood. So in the breast cancer population, this is a study done by Hannah Sanoff and those down at UNC. We see this 10 years acceleration related to anthracycline chemotherapy, and in transplant, we see approximately 33 years. Not only that, we wanted to compare this relationship with this molecular marker of aging with other geriatric factors. So again, going back to the clinical hallmarks of a geriatric assessment, looking at the relationship between function, fatigue, cognition, anxiety, depression, and social support, we saw a modest relationship of P16 expression with fatigue specifically identified here. So not only that, we wanted to explore the T cell changes when it came to transplant for patients with multiple myeloma, to be able to characterize these shifts that we see within their T cells over the course of time. There are natural changes that happen with T cells that can be related to aging, such as reduced expression of CD28 and expansion of T regulatory cells, which we see quite commonly. This is an infographic really kind of describing what a T cell composition is supposed to look like for a healthy patient, what it looks like when patients have cancer, and what happens after transplant. So you can see these big shifts, the CD8 and CD4 inversion, this expansion of effector memory cells, and this consolidation of central memory cells that we see over time. But we were able to show that in this case, that transplant induced this global transcriptional changes across the pattern when we looked at molecular markers, markers of cellular exhaustion, markers of energy across our patient population, looking at different T cell subtypes. One of the markers that we found to be most clinically related to event-free survival, which in this case was relapse or death, is that this marker called LAG3. So we identified patients, if they had high LAG3 expression, that this was associated with inferior survival for patients who had this expression within their T cells. Importantly, these T cell transcriptional changes that could be identified, these are serum changes that we're able to characterize within the T cell population. And it's not a whole story, but the starting of a story, but to be able to say that this T cell exhaustion and T cell dysregulation is an important part of this aging phenotype. So in summary, there's a couple things when we talk about the geriatric principles where we can clinically look at things and biologically look at these geriatric principles, be able to define fitness. And really being able to partner our clinical alignment using our allied health services in partnership with our biologic advances in aging science are really an important part of moving the field of cancer and aging forward. So again, the geriatric assessment can be used to estimate survival, but it's comprehensive in the sense that not one of these domains is more important than the other. And assessing their comorbidities, which we're very well, we're very good at assessing their comorbidities and designing a therapeutic plan. But looking at their non-oncology plan, their social roles, and the required resources really are a better measure of estimating survival for our patients and being able to best suit them over the course of time. Now, as I mentioned to you in this clinics and really keeping this alignment with our health services is one way to be able to utilize resources. But at the same time, there are online tools that are very well established to be able to estimate things like chemotherapy toxicity for your patients who present in the clinic. So as one example, and this is probably the best example and the most well-studied example, is Dr. Huria's CARG, the Cancer and Aging Research Group Chemotherapy Toxicity Calculator, where many of these geriatric assessment domains that were identified within our plan, you can estimate that using this calculator, that they are better predictive of grade 3-5 toxicity than a physician estimating their performance status alone. So this is an easily readable tool that you can use in your clinics to be able to characterize and estimate risk of chemotherapy-related problems. So in conclusion, a geriatric assessment is really a global approach to measure health that can be both predictive and prognostic for our patients. Integrating age-specific assessments and aligning our allied health services will really help move our services forward, particularly in light of the physician shortages that are anticipated. Not only that, the future of the aging science is really important for us to be able to characterize health status both clinically and biologically for us to be able to move the field forward. In conclusion, I just want to thank our teams, and my email and my Twitter are there in case there's other questions. Thank you.
All right, thank you so much, Dr. Rosko. That was phenomenal. It's amazing to think of when you started that journey to where you've taken it. It's really, you should be proud. You've really just done amazing things. So for folks on the call tonight, if you want to post a question, you can pose it on chat, and or raise your hand and ask a question. But I'll start while we're waiting for people to come in. It was so comprehensive to look at whether it's behavioral issues, the frailty, risk scores, et cetera. And then you tied it all in with some of the molecular tests. What have you done as far as looking at trying to catch people at that earlier part of the elderly population? So as they're hitting their 60s and doing things around activities and healthy living and caloric restrictions and those types of things, to see if you can shift what that looks like when they start getting in the 70s and 80s.
Yeah, I think an important part of the clinic is that we want to be able to, the clinic is open really for any patient. They can be newly diagnosed, they can be previously treated, they could be on treatment. And it is really identified for us to be preventative in the sense that many of these things that we're doing within the clinic are not part of everyday clinical care. Oftentimes, and you may experience this too, is that when patients present, it can be more reactive, that we see somebody losing weight and then we are like, oh, let's make sure that you're getting, like, we're going to send you to the dietitian, or let's get a better sense of what you're eating and drinking at home. As opposed to in this case, they may not come to our clinic specifically for weight loss. Maybe they're coming to the clinic because they've seen it, or they're coming from some other functional need, but we're characterizing that and measuring it. And I think that a lot of the focus of our clinic is really meant to be preventative and more prehabilitative over the course of time. So a good group of our patients, as you can see, like when we characterize patients who have frailty within our patient population, we had a fair amount of our patients who had many geriatric deficits, 5 to 8, because our oncologists or those in the community are sending patients to us because they are finding things. And then there are other patients who are really, trying to be like, we're identifying some mild changes. Is this related to chemotherapy? Are they experiencing things like chemotherapy brain and, or changes in neuropathy that they didn't necessarily know to be neuropathy? And we can either use medications or talk to their oncologist about their dosages of their chemotherapy. So I think that the clinic is supposed to be both predictive and prognostic for the patients, but to be as preventative as we can for those, even though, like, say, for example, if you come in for one thing, you're still getting the rest of the needs. And that's part of what a geriatric assessment really is. It's really comprehensive, and it's a global approach independent of what need that you're being referred to.
Awesome. One other question I have, and please, if you have questions, go ahead and enter them. Can you just touch on how do you get other providers to be engaged with your program? One of the things, we started a geriatric oncology program, and I think the natural inclination, since so much of cancer is in the elderly, people say, well, I do geriatrics because I care for all these cancer patients. So how do you get them to understand that you are providing an amazing service and it really is comprehensive? And maybe give us some tips on what you saw that maybe we can glean some help from.
Yeah, I think that's a great question. So I think that I actually still get that feedback about, by default, I take care of X cancer and therefore I actually do all these things. But we do, kind of really, do this kind of one-stop shopping and saying, well, what memory testing are, how can we best serve? Because I think part of it is that there are some things that are not obvious, right? When someone's coming into the clinic, and a lot of what we do is really identifying occult changes, because we are doing things like memory screening, we are doing audiology screening, those types of needs. And some people may say that, I don't think my patient populations need that, necessarily. But I think the buy-in has been an important part of those resources. And I would say is really what a lot of patients, say to me in the clinic is that I come here to the cancer center so often, yet I have to go back to somebody else, or I get routed to 7 different places, and I have a part-time job that is going to the doctor, especially when a cancer diagnosis comes. And so, really a sell for us is to say, well, let us, absorb that for you. Let us be the one-stop shopping. So we are not allocating your patient or the caregiver specifically, or or their partner, their spouse. A lot of people take off time, for work to go with people to these medical appointments, right, to understand what's going on. And we're saying, let's try to consolidate that. And so we're not making our patients or our caregivers have to go to 7 different places for what we can do within one visit. So that's one day off for work for the patient or for the caregiver. It's one clinic visit. And so that's kind of a big sell of our program, is that we want to be able to make this something that is available for everybody. And then also at the same time, that the nature about the oncology workforce is the fact that, we're gonna have more and more patients, and how can we best care for them? And so that's why the creation of this clinic was really to create alignment between our patients and their needs, and then what a busy oncologist is doing to be able to create a service for patients as part of their care. Does that answer your question?
Yeah, it does. And I would say I really love the fact that you've brought on correlative markers to go along with your research, which is incredible. Here's a question for you from the audience. When was your program started? How did it evolve? And really maybe speak to the identified gaps that you found along the way that you filled, and maybe a lesson that you learned along the way.
Yeah, I would say so our program started in 2016. So the clinic has been running for 5 years. I think one of the biggest challenges for our clinic is geographic localization. So every cancer center is different, but I think one of the things that we identified is that patients don't necessarily like to travel outside of where they normally go for their cancer care. And so we may have one type of cancer in one building, another type of cancer in a different building, and where our clinic is located is someplace else. And so I think one of the co-localization is an important thing to honor for patients and for caregivers, is that we want to be able to offer those services. And the fact that we're located in one place and many other cancers are treated other places, that's definitely been, I would say, a gap when it comes to our clinic, is being able to get to different services that where patients aren't used to going. I think it's a big challenge, and probably for you have something very similar at a big cancer center. It's just the convenience of getting going one more place. But if you're already going there, it's a lot easier. But having to go to a different building or a different, like walking there, parking there, traveling. So one other thing that we did during our COVID pandemic is that, like you, many of our patients are coming in from rural communities or traveling hours upon hours to come to the clinic, and would benefit from these services, but at the same time would have to have a 2-hour round trip. So we went virtual with our clinic. And so we have, it's very similar to something like this on the Zoom, where we're all listening in. So this was a service that was designed specifically for patients who either are working or live in rural communities, where they're able to have a multimodality clinic where we do the same assessments. Obviously, it's a little bit harder to do a functional assessment or a hearing assessment, so we don't have audiology on our virtual calls, but we have we still have our physical therapist that talks about safety within the home. So that's something that I think has been a gap. So one gap is the geographic localization, and the second is the ability to pivot and to go virtual for patients who would need this type of service.
Great. A couple other questions, if I could. When you do a global assessment with memory evaluation, is there a guideline around treatment recommendations, chemo, et cetera, in individuals with significant cognitive impairment and impacted pre-treatment quality of life?
Yeah, so I think that's a challenge. So one of the challenges that we find for patients who have cognitive impairment, so it's a risk factor when it comes to specific therapies in terms of accelerating. For example, we see a lot of transplant patients within our clinic, and we can guide patients to say that we have tracked cognitive impairments. We and others have looked at cognitive changes and see, especially when it comes to attention over the course, and it's expected to return back to a year, but in some cases it does not. So it's more of a counseling than it is that we would tell patients that, your therapy needs to be changed per se, but it's a risk factor when it comes to more intensive therapies. And I think that's been one of our biggest challenges too, is and finding reliable resources for our patients. We have some resources in the community for those who are established to have severe cognitive impairment who come in within the clinic. We have driver's rehabilitation for patients who had maybe a significant hospital stay and want to get back to being independent, things like that. But we don't necessarily have a prescriptive plan in terms of like chemotherapy changes when it comes to patients who are cognitively impaired. But more so, we use it as like let's see where things are now. Let's do another assessment in 6 months to see if things are really changing or they're staying at a plateau, because that's an important part of health-related quality of life.
Great. All right, thank you for introducing this comprehensive service. Would you speak to the role of palliative and spiritual care services?
That's a great question. So I think that also goes to, so one of the things that we did actually this past year, which is a little bit challenging, but we identified that patients, we're a consultative clinic, so patients can come to the clinic once, and then we oftentimes create this plan for patients to go back to their primary oncologist. But one of the things that we have identified is that we did need additional support services specifically focused around palliative care for patients who are not necessarily end of life care, but need additional supportive care longitudinally over the course of time. And so I didn't put that into the presentation, but this past year we actually expanded to create a clinic that's called Care Pal Clinic. So we recruited a specialist who was fully trained in geriatrics and palliative care. And so if we identify patients who have, really need a lot more, who are frail, who are vulnerable, and need a lot more additional support, we can refer those patients to what we call our Care Pal Clinic, which is actually, it's kind of basically our sister clinic in which we allow, which patients who we characterize globally but need a lot more services, and that we want to be able to provide those adjunct services along the course of their trajectory. And so we've expanded to include this Care Pal Clinic actually just this past year. So I'm really looking forward to looking at some of the data when it comes to health-related quality of life for those patients, especially if they come to care, we measure their quality of life before they go to Care Pal and just over the course of time compared to patients who don't necessarily have those services.
All right, the last question, Dr. Rosko, has your program been patented and sold/shared with other university or really any healthcare settings for onco treatment and clinical education?
So I put the map of that when we created this clinic. So when we were doing, benchmarking to other clinic and to other geriatric oncology services and multi-D services, we really noticed that this care plan was emerging as a need specific for older adults. And so from that, I work with a national team called the Cancer and Aging Research Group. We are a national network focused specifically on older adults with cancer. And from there we created a core called the Clinical Implementation Core. And so that core is really to help other institutions, other centers, other clinics be able to create, because what works at one center may not work at the next center, but this concept is important. There's value to what we do in terms of doing the geriatric assessments and creating a personalized intervention for our older adults. And so we really want to be able to disseminate this and utilize our services. And I think I talk to, different people and different teams, maybe even like once a week in terms of how do you do this or how can you retrofit it to make it work in different clinics, what resources are different, investment is different across cancer centers. But we created this clinical implementation core through the Cancer and Aging Research Group specifically with another group of investigators who have either clinics or models similar to ours. And so we can create and disseminate this idea that this is doable and that your patients want this and your caregivers benefit from this. And here's one way to do it. There's also many different ways to instill this model of geriatric oncology care delivered in concert with routine oncology care.
That's awesome. Well, I want to thank Dr. Ashley Rosko. I mean, I'm probably like everyone here blown away by the level of expertise and the quality of the talk. Ashley, really great to see you, and I appreciate all you're doing for geriatric oncology and really changing the paradigm by which we care for our elderly patients. And I want to thank the audience for taking time out, and certainly want to thank the Nixons for all their support and the Norton Healthcare Foundation Just incredible partnership and how we go about really expanding the understanding of cancer care. So as Russ Cox would say, thank you, stay safe, and keep the faith. Thank you, everyone.